Yeah, next slide, please. As we know, this is a regional outbreak. We are saying that because we have at least 2 countries affected. We have DRC, we have Uganda. And we can see the number of suspected cases. That is from yesterday data, around 1,077 cases and 246 suspected deaths related to this Ebola outbreak. We are supporting the government to conduct active surveillance and to start to understand all contacts and to test them and to isolate them. We'll talk about it when I will share about what we are supporting, what we are providing to support the government. Next slide. This is the second largest Ebola outbreak. The first one was in West Africa in 2018. And this outbreak that we are experiencing in 2014, this outbreak we are experiencing today, we already have more than 1,000 suspected cases. When you see 914, because the slide was prepared before the update that we got. But when this outbreak was declared, as you can see in the first graph, we already have 246 suspected cases, while for all other outbreaks, when we declare that we have less than 100 cases. It means it's not, we can discuss the delay, we can discuss what we think that would be done at that moment. But what is the truth? What is the reality is when the outbreak was declared by Africa CDC on the 15th of May, followed by Uganda and DRC, we already had 246 suspected cases, and that one, we can see after 10 days how the number of cases are increasing. This number of cases is increasing not because we cannot say that.
How will we unlock economic and social prosperity through environmental responsibility? With EY's full spectrum of services across sectors, we're all in to shape the future with confidence.
We are still expecting in Africa CDC an increase because we are still in this active phase of the outbreak. Next slide. We have 2 countries affected, but we have 11 countries at risk. We were talking about 10, now we added Somalia. This is why we have 11 countries. These 11 countries will also be supported for the preparedness plan, because we don't want countries not to be ready if they may be contaminated in the next few days. But we are doing our best to stop this outbreak in these 2 countries and to contain that. Next slide. When colleagues are asking, did we take appropriate and timely action? This is the answer. On the 15th of May, when we got the evidence that this outbreak was in more than 1 country, it became the mandate of Africa CDC to declare the outbreak. But for us to declare the public health emergency of containment security, there is a process. This is why the next day we started to look for evidence at scientific level and to start also to mobilize political leaders to talk with head of state, to talk with the chairperson of African Union Commission, while we are also supporting the response on the ground. 3 actions at the same time. The next day of the declaration, it was the 16th, we called for a meeting of all partners. We had around 130 partners connected. And the day after this meeting, we had the declaration from WHO of the Public Health Emergency of International Concern. And because the process for Africa CDC was also ongoing, the following day, Africa CDC declared the Public Health Emergency of Continental Security. I was on day 3 in the field. I stopped my engagement in Geneva. I flew the next day to DRC. The 3rd day, I was in Kinshasa, then in Bunia, at the epicenter of the disease, visiting the hospital, meeting leaders, talking with communities, sitting with people who are affected to understand what is the message they are giving us. Because most of the time, we are acting from our offices in Geneva, in New York, in Brussels, in Addis Ababa. We don't know what these people they think. This visit opened my eyes on what are the real needs of the population. And this visit was also a clear message on the mistrust that exists currently between African people and Western countries. The question they are asking me, DG, why after 19 years of this outbreak, we still don't have a vaccine? We still don't have medicine. And they are telling me, as a local leader was telling me, if this outbreak was in Europe or in the US, the vaccine and medicines will already be available. This is the message that I'm relaying to you, member of the media. The message coming from the community that is affected. What we did, the next day, it means day 4, we organized a ministerial meeting in Kampala, bringing all ministers from DRC, Uganda, South Sudan, bringing all partners, discussing and having one joint response plan of 319 million for countries. This is what Africa CDC did. And this is what is making this response more robust, because appropriate action was taken timely. Next slide. If we don't take action, what are we facing? Yes, we are losing people. We lost 3 very young medical doctors in Bunia. They have hope to become successful doctors in their life. But in addition to medical doctors, we are losing health workers, nurses, community health workers, and members of communities. On top of that, we are also making our economy down. For all of you, in West Africa, when we have this Ebola outbreak, we lost $53 billion. That costed 12% of their GDP. But if we decide to work together to invest on appropriate actions, knowing that we don't have vaccine and medicine approved so far, by supporting the public health measures, the return on investment is for $1 we're investing, we are getting $7 back. And this is from economical perspective what we need to do. Next slide. We started to mobilize communities, leaders, as you can see, President Museveni, but most importantly, private sector also. Because we believe it's time for private sector to understand that with these travel restrictions that the world is imposing, for your information, we already have 15 countries imposing some forms of travel restrictions so far. It means business will be affected. I want to thank my dear brother Aliko Dangote, Orama, George Elombi, and so many others who are working now to bring all businessmen together to have a meeting where they will pledge, but will also see how to support the overall response to outbreaks in Africa. Next slide. I landed in DRC yesterday, coming from Brazzaville, where I had successful meetings with a number of colleagues, partners, including Baroness Chapman, the president of FDB. And yesterday I was in Kinshasa. I had the opportunity to meet His Excellency, the President, because I requested this meeting. And he called senior people from the government to meet with me and to discuss the response. The Prime Minister was there, the Minister of Health was there, the Minister of Communication, and other senior officials from DRC. We took 3 hours, 30 minutes for the President to discuss all pillars, what DRC is doing, what DRC is committing. And the main information is the President told me on daily basis is following, is providing guidance, and is leading the response. This is what we are expecting from a leader during the outbreak. I'm also glad to share that the initial response came with money that DRC provided, 20 million, and now they are increasing that to have more funding that will be around 15 million in the next 2 weeks. The President decided also immediately after that meeting that we had yesterday to send 2 ministers in the field. Now that I'm talking to you, the Minister of Health and the Minister of Communication are in the field, are in Ituri, organizing the response and making this region ready to stop the outbreak. Next slide. Next slide, colleague. How are we responding to this outbreak? In Africa, we are led by a major lesson, Mpox. For the first time, the continent came together, putting Africa CDC and WHO together, supporting member states based on their plans, and working closely with all partners. This is what we call Incident Management Support Team, IMST. All of our leaders, all of our ministers, all of our partners who want to work with us, we are all saying we need one plan, one team, one budget, and one implementation model. Without that, we will not achieve what we want to achieve and will waste resources. We don't want the current Ebola outbreak to be like what DRC had a few years ago, where 1.2 billion were given, but no one knows the impact of that. No one knows what was built with this 1.2 billion. Now, with Mpox, we can see the legacy of Mpox. Even the increase of the lab network in Africa, it's thanks to the Mpox legacy. We believe that with this Ebola outbreak, there will be also a legacy. Next slide. This is how we are organized. We have a number of partners who are there. I want to thank all of them. Yesterday, we had a meeting with more than 200 of them, co-shared by my brother, Pastor Janabi, and myself. And we have a number of pillars where each of us is providing input and support. We are working closely together, and I thank everyone. Next slide. These are the 11 pillars that we have, but I want to draw your attention to the last one. The last one is mostly for countries where we think the risk is high and we need to prepare them. Tomorrow, I will be in Burundi, meeting the president and senior officials to see how the country is getting ready if the case that we have in South Kivu can be detected also in Burundi. This is why we are really running. Let me correct, we are not running, we are flying to make sure that we can stop this outbreak very quickly, but I cannot say when. Next slide. Next slide, please. How much? In Kampala, we agreed for countries to get $319 million. This is the figure that was approved in Kampala by ministers. On top of that, next slide. On top of that, we have also funding from partners to support the country response, and partners so far, we got requests around 148 million. Is it correct? Is it accurate? No, because other partners are still providing their figures. That's what can change. But so far, we are talking about 467 million, 319 million for countries, 149 million almost for partners. As I said, this figure will change because we don't have input from all partners. Next slide. What are we asking? First, to member states, I really want to thank the 3 countries that had the opportunity to meet in Uganda, and they agreed for the cross-border activity, and they requested Africa CDC to support them. And for your information, this meeting took place because I received a letter from the Minister of Uganda calling Africa CDC to organize this meeting. And you saw the communique. There is this strong commitment to conduct cross-border activities. We are also calling countries to provide financial support to the response, because this is the sovereignty agenda we are talking about. About our communities, we know the challenges that they are facing. I will again go back to Ituri in a few days. I will be working with colleagues, with ministers, supporting them, but they have to trust us. They have to know that the government and partners they will continue to do everything possible to support and to stop this outbreak. Because we start to see this mistrust, partners, they came together, they say, we are pledging resources. On Monday, 25th, we ended the day with a pledge of $498.8 million, almost $500 million. Since then, the figure is going down. Now that I'm talking to you, the figure is around $290 million. We cannot afford to stop this outbreak without resources. We cannot afford to stop this outbreak just with political declaration from some countries. And more importantly, we cannot afford to stop this outbreak with travel restrictions that Western countries start to impose to African countries. It's even ashamed to see a country like South Sudan with 0 cases, 0 suspected cases, 0 death under travel restriction. Who can come to explain to me why South Sudan is under travel restriction? The treatment that Western countries are applying to Africa, I will continue to talk about it. It's my role to talk about it. It's not acceptable. The same way I raised my voice in Rwanda in 2024, when Rwanda was under travel restriction because of the Marburg outbreak, we are raising the voice today. We say no in Africa. We are calling for a meeting of head of state in a few days. This message will be strong and loud. We are also calling our own African countries to understand that it's just by reinforcing public health measures in the border, then the Africa CDC will be working with you, that we can stop this outbreak. We don't have to close our borders also to our own brothers and sisters. Next slide. I want to thank WHO colleagues, the leadership of Professor Janabi is critical on the way we are working together. I want to thank my brother Tedros for the support and for the strong collaboration. But let me also thank my own Africa CDC colleagues. They are working hard. Most of them, I have around 42 colleagues in the field, working to provide support in all areas. Thank you so much to all of you, to all partners, but also to the members of the media who are helping us. I will stop there and give opportunity for the conversation for the next 1 hour we have. Over to you, Nick.
Thank you, Your Excellency, for the very comprehensive update. As we said in the introduction, our Excellency is also supported by senior technical experts from the IMST, as he has mentioned, and of course, heads of division across Africa CDC who will provide responses to your questions. Today, our questions will begin with some of our colleagues are asking in French. I've managed to translate them. So if you prefer, Your Excellency, you can respond to them in French. The first question comes from our colleague, Anisette Kemonyo. She's from the Tazaman News in the DRC. Her question is written in French, but the translation is, what communication strategy can be used to build trust between the public health and, of course, the workers, and as well as the community in response to the new strain of the Ebola virus? That is an innocent question. Another question that comes in French as well is from our colleague Maria Mondeja. She writes for the El Periodico in the DRC as well. And she say, her question is written in French as well, but the question translated says, how are cuts to international aid funding affecting the response to this outbreak? And what distinguishes this outbreak from the previous outbreaks? So those are two questions. I will allow Your Excellency to respond. Preferably, you can respond to these colleagues in French if you like. Thank you, and over.
Merci beaucoup. Je vais vous répondre en français puisque vous avez posé en français et puisque vous êtes des médias du pays qui est affecté. La stratégie de communication va se construire autour de la communauté. Nous devons avoir des leaders communautaires engagés. Nous avons vu des scènes où les jeunes gens ont voulu prendre des corps des personnes décédées. On a vu des scènes où des jeunes gens ont détruit des structures. Ce n'est pas des gens qui viendront de Kinshasa qui vont leur dire d'arrêter. Voilà pourquoi j'apprécie l'initiative du ministre qui est parti avec le ministre de la Communication sur place pour essayer de résoudre ces problèmes, de mettre les communautés ensemble, de les écouter et de mettre en place des stratégies appropriées par rapport à leurs revendications. Je pense qu'avec ce que nous avions discuté ensemble, avec les membres du gouvernement et les chefs de l'État, avec la volonté que j'ai vue, avec les informations que j'ai de ces communautés que j'ai rencontrées, tout ce que nous avions vu dans le passé risque d'être le passé et qu'on ne les reverra plus. Puisque la stratégie de communication maintenant, elle est basée sur les réalités des Ituri, avec les gens de l'Ituri, avec des jeunes qui ont des messages à passer, mais surtout avec la confiance que nous restaurons entre la communauté et les autorités et les partenaires. Comment est-ce que la deuxième question...
Will it rain today?
Rain expected this afternoon. Don't forget your umbrella.
Sur le terrain comme la collecte des échantillons, le transport des échantillons, l'analyse des échantillons. Nous avions même des systèmes de transmission des données qui dépendaient de ces partenaires pour fonctionner. Tout cela est tombé du jour au lendemain. Oui, je veux le dire, la diminution des ressources a eu un impact négatif sur la capacité des pays africains à détecter, à tester et à reporter les épidémies. Mais nous sommes en train de passer cela. On ne parle plus de cela. Aujourd'hui, l'Afrique est debout. Un pays comme la RDC va investir au moins 50 millions de dollars qui va constituer une bonne partie des ressources pour la réponse. Ça n'était jamais le cas dans le passé. La RDC attendait les partenaires extérieurs. L'Ouganda fait de même. Donc, nous avons pris conscience en Afrique que notre futur dépend d'abord de nous. Et c'est cela, ce que moi j'appelle le plus grand message de cette diminution des ressources. Over to you, Nick.
Merci, Excellency. We'll take our second batch of questions from the ones that have come in here before we go to our colleagues who have raised their hands online. So our next question comes from our colleague from the BBC, who is based in the DRC, Emery Makomano. His question is around vaccine. He says, are there therapeutics and or vaccines available to be introduced in a move to halt the rapid spread of this current strain of the Ebola virus? Second to that question comes from our colleague Monica Moyine. She's a freelance journalist in Zambia. She writes for the Zambia Daily and Daily Nation. Her question is also around vaccine. And Monica asks, how soon are we likely to receive the news of a vaccine for the new strain of the Ebola virus that has hit the DRC and Uganda? So those are the two questions around vaccines. Over to you, Your Excellency.
Thank you so much. So far, we don't have approved vaccine and medicines. We have some candidates. I will say it also. Yesterday, I received a message from the Minister of Health of Russia informing me that Russia already developed a vaccine. My team is working with the Russian team and with all other partners to understand. We also know that some ongoing studies are there, and I don't want to talk about what is not really evidence so far, but we have some candidates. I cannot give you the timeline because when we are discussing with the team and other partners, what they are giving us is so different depending on candidate vaccine. But what we can tell you for sure, by the end of this year, 2026, Africa CDC will make sure that we have vaccine and medicine against Bundibugyo. If one day we have again a fourth outbreak of Bundibugyo, we'll say we have vaccine and medicine. Our leaders are ready to invest. We are investing at technical level, at strategic level, to make sure that this one will happen. Next question.
Thank you, DG. Now let's go to our colleagues who have raised their hands on the Zoom platform. We have a couple of them. We will take your questions in order as the hands are raised. So first we have our colleague Bonja Kaur. Bonja writes, is based in New Delhi. She's the science or health journalist based in New Delhi. Bonja will be the first. Bonja will be followed by our colleague Gabriela Emmanuel from NPR based in the US. And then we see our colleague Sarah Jevin from Deves. So we'll go in that order for now, and then we receive answer from Your Excellency, then we take the next batch. So Bonja, over to you.
Hi, thanks for taking my question. DG, you said emphatically in your last press conference too that had this outbreak happened in the West, you would have vaccines and therapeutics by now. And in this press conference also, you emphasized upon that. I was wondering, when you say that it is the West which was not very, maybe not very kind towards development of these vaccines and therapeutics. What exactly do you mean by West? Apart from dwindling of funds and the shortage of funds, do you think agent vaccines and therapeutics or international agencies, who exactly do you mean in the West did not invest enough in vaccines and therapeutics for this particular strain of the virus? Thank you.
Thank you, Bonja. Next is our colleague, Gabriela.
Hi, thank you so much for doing this as always. I wanted to follow up on what you were saying about building trust, and if you could speak a little bit more about the specific strategies on the ground. And for this, you mentioned these were kind of a younger population, how you're reaching, or how the public health community should reach this kind of younger population that's been attacked some of the treatment centers. And what you, I guess, have learned from past outbreaks about how to build that trust. Thank you.
Thank you, Gabriela. The last one for this batch will be our colleague, Sarah. Sarah, over to you.
Thank you so much. I'm wondering if you can give us a few more details on the vaccine candidate from Russia that you mentioned. Is it already in clinical trials? And kind of what stage of clinical trials is this vaccine in? Are there doses already available? Is it specifically approved for the timeline for getting it on the ground? So.
Thank you, Sarah. Your Excellency, you can answer those three.
Thank you so much. Let me start with the first one, and the second one, I will also call my colleague Chanel and Mosoka for the vaccine candidate. Banja, let me first thank India for the 30 tons of surplus we are getting. Please, when you'll be reporting, share that Africa is grateful for the support we are getting from people from India. Regarding the treatment, the unfair treatment, as I said, to African countries. When we had Ebola in West Africa, we lost 1,000 people. It was when an American medical doctor got the disease, was sent back to the US. Then we discovered that the world has a solution to this Ebola outbreak. Are we still in the same case? I don't know. Do we really think that we don't have any solution? I don't know. But what I know for sure, if this outbreak was in Western countries, they will collect samples, they will conduct research, they will develop vaccine, they will develop medicines. I know that, I believe that. And this is why I say it's time for us in Africa to start to think about how to accelerate our local manufacturing of vaccines and medicines. I will not blame them, but I'm sharing that my people, they think this is the unfair treatment. Regarding building trust with Gabriele, when I was in Ituri, I was asking the communities, what do you think about this outbreak? Yes, some of them, they were thinking it may be not a real outbreak because there is a history regarding someone who passed on and the wife didn't really do the right thing in terms of funerals. This is why the guy is coming back to look for others who are still alive. But you know, there are not more than 10% of people believing that. The majority knows that the outbreak, the disease is there. But what is the issue that is creating this mistrust? The first one, why do we have vaccines and medicine for other diseases, but for this one we don't have? And they believe that medicines and vaccines exist, but we don't want to give them. It was the question they were asking me. Why did you don't want to give us what you have? The second reason of mistrust, all announcements that partners are making, $100 million, $50 million, I don't know what.
Got hosting at $99 and then paid 3 times more at renewal. That's how most hosting companies work. Big discounts in year one. But when it's time to renew, the real bill shows up, and that's when it hurts. At Miles Web, what you see is what you renew at. Same price at renewal. No hidden hikes, no surprise shocks. Just transparent, honest hosting. Switch to Miles Web today and stop renewal surprises for good. Miles Web, hosting you can trust.
This insecurity that is affecting them, and that is not allowing them to have access to health services they need. To rebuild trust, we need to respond to them and we need to involve them by listening from them. This is why today I'm saying clearly, loudly, we don't have vaccine, we don't have medicine. They must know that. And the second message is we are doing our best to provide funding. What we have, we are coming back, we are giving you. And the third message is you'll be leading your response yourself. You are responsible for your community. We'll give you all tools. Especially for the communication side. But for medicines, for PPE, and other aspects of the response, we'll do our best. I can tell you that I start to see from what I'm getting, change is coming, and we'll take it from there. I will ask Mosoka and Chanel if you are connected. Are you connected for the vaccine candidate in Russia. Otherwise, I will move on. Chanel?
Yes, hi, Didi, and hi, colleagues. So we're still learning more about the vaccine, but what we do know is that it was developed based on the 2014 to 2016 outbreak in West Africa. So it targets the Zaire Ebola virus. It was developed by the Gamaleya National Research Center in Russia. It's a viral vector vaccine. I mean, we know the specific platform is RVSV plus adenovirus 5 vector combination. But we have further meetings this week with the Gamaleya Research Institute, so we can hear from them more about why they think that this vaccine can have impact on this strain. So we will keep you updated as we learn more. Thank you.
Thank you, Chanel. Thank you, Your Excellency. Let's go back to our questions up. The hands that are up, we'll pick another 3 of our colleagues, this time in the same order. Paul Adepuju from the Lancet will go first. He will be followed by Naomi Kasige from Bloomberg. And of course, after Naomi will be our colleague, Rachel Abuja from the News Agency of Nigeria. Let's go in that order, colleague. Paul, you are first.
Yes, thank you very much for taking my question. My first question has to do with more clarity regarding the state of the infection among health workers. If we have insights around the proportion of the cases reported that among health workers, and whether this was very early or we are still seeing rapid number of cases in the newly detected cases among health workers. And you've been talking about the interventions. I know that in the case of Bundibugyo Ebola, survival samples from earlier Uganda outbreaks have contributed to antibody discoveries. So what do you consider to be fair return when African survival samples help generate promising countermeasures? And to what extent do you think Africa can start expanding its research capabilities such that cases like these don't have to be solely dependent on researches conducted outside the continent? Meanwhile, we have these cases happening on the country. We have survivors that have circulating antibodies in their blood systems. So what is being done such that Africa research ecosystem is able to stand up to the occasion? Thank you very much.
Thank you, Paul. Our second person is Naomi. Naomi, it's over to you.
Hi, thanks for taking. Hi, thanks for taking my question. You said that you ended Monday with 498 million in financial pledges and that the numbers have actually declined since then. Could you tell us exactly how much has been pledged at this point and who has pulled out since Monday? Thank you.
Thank you, Naomi. Lastly, for this bash, we'll take Rachel.
Thank you so very much, Nick, and well done, Profi and your team. With the sharp reduction in international funding and sudden collapse of external support, which I'm aligning with Naomi, surveillance and laboratory system, how realistic are we in transition towards full domestic funding or financing of outbreak response, and what risks remain during this shift? Again, this is not the first time we are responding to Ebola outbreak, of course, in West Africa, and of course, in Congo. Didier, I would like to know, what have we not done from all we've gathered in the past years? Is there anything left that we've not looked into? Thank you, and over.
Thank you, colleagues. I will respond to Paul's question and to Rachel. My colleague Todber will respond to Naomi's question. Paul, in West Africa, we saw that infection rate among healthcare workers was around 2 to 50%, depending on preparedness and availability of infection prevention measures. Where we had PPE, where we have good preparation, health workers were not so badly affected. But in the early stage, when this outbreak started without information, and let me remind you that in Liberia, the person who was leading this outbreak is Dr. Tolbert, who is now with Africa CDC. And we also know that in West Africa, nurses and nurse aides represented more than 50% of infected health workers, because nurses are those who are first receiving patients. Unfortunately, 68% of them passed on. These are statistics. We started to see similar trend in Ituri, because when this outbreak started, the first test that was done on the 5th of May using the Zaire strain was negative. People, they were thinking it was not Ebola. They were thinking it was a severe malaria or maybe other diseases, but not Ebola. This is why we have so many health workers, doctors, nurses, nurse aides infected. Now, with all PPEs that we are starting, we are providing, we see less and less health workers being infected. But your question...
Cracking JEE is tough. Long hours, doubts, pressure. But you don't have to go through it alone. Allen Online has brought JEE self-study courses for you. You will get recorded video lectures designed by Allen's best faculty, available in Hindi and English. Official Allen Online study material soft copies, books, exercises, races, and more. Test series. 20 smart tests based on the latest JEE exam pattern. Self-paced, expert-guided, perfect for your schedule. And it is starting from rupees 7,000. Enroll now.
Others are imposing travel restrictions. If tomorrow we discover that some of them have already vaccine and medicine, how do you think African people will consider these people already have that? This is why during the negotiation on the pandemic agreement, we came with a strong component of pathogen access benefit sharing, PABS. Unfortunately, we didn't finalize the negotiation for the last WHO. We need to continue. What it means, pathogen access benefit sharing, we need to benefit from our pathogens. We don't want to beg every time we have an outbreak. We are no longer begging, we are taking action. Africa CDC is developing capacity, building capacity of African countries to manufacture. We made a lot of progress. We created African pool procurement mechanism. We empower African Medicine Agency. We know how we are providing incentives for African manufacturers to start to manufacture. We are facilitating the tech transfer. Since COVID, we made some progress. But this outbreak will teach us to accelerate the progress that we made. Rachel, what Uganda didn't do to face again another outbreak? No, I will not phrase it like that. I will say Uganda did the right thing. Let me remind that the first 2 cases in Uganda came from DRC. People who came to seek healthcare support in Uganda. It means they are imported cases. And when these people came, nobody knew that they had Ebola. But in 3 days, 4 days, they were tested positive to Budubungyo, and the government took appropriate action. I was briefed when I was in Uganda about the protocol that the government is following. And I want to thank them for the transparency. So far, we don't have any evidence of community transmission in Uganda. Cases that we have in Uganda are mostly linked to the imported cases from DRC. And we'll continue. What to do? Your question. We need to continue to build our capacities and to make sure that in terms of surveillance, in terms of detection, in terms of protection of health workers, in terms of behaviors that we have, we'll continue to work on that. And it will help us in the future to not to be infected by another Ebola outbreak. Tolbert, please, can you answer Naomi's question?
Thank you, DG. I think Naomi wanted to know what are lessons from previous outbreaks and what are we still having these frequent outbreaks. And so I will attempt, Naomi, to tell you that this outbreak of Bujubujo, and there are some similarities. First of all, that I wanted to throw out there. The way it is happening, like the Ebola that the species that was, and the most virulent one, the most difficult and can kill faster, to put it in a lower term, in West Africa, was that we started the outbreak in West Africa with the same theory of no vaccines and no therapeutics. The Bujubujo species that we're dealing with right now in DRC and Uganda, the similar theory that we are starting with. So what are some lessons learned that we are applying right now? As the DG mentioned to you, when you don't have the medical countermeasures, you use the public health countermeasures. And what are those? He just mentioned to you, surveillance are some of the lessons we learned. We have to increase our disease surveillance. We have to increase our testing. We have to ramp up contact tracing. We have to do community engagement, which is important. Engaging the community so that people are not hiding cases in their homes or treating them in their homes. Because we learned those lessons that if you engage the community with multiple communication channels, using radio, using talking to traditional leaders, religious leaders, and all of those communities, social mobilization can help. And the situation, what we also learned that we need to apply here is the humanitarian crisis that is taking place also in the area, the Ituri region and other areas with conflicts, poverty, farming, and other things, other endemic diseases. We need to have a whole package under the incident management support teams and our partners. And also, some of the things we're doing right now is the ramping up of the research to find vaccines. You know that we were in the middle of the outbreak of the Ebola outbreak in West Africa, when DG just mentioned to you that there when we found the some therapies and the vaccines that we use, when you trace the contacts, you deploy those vaccines and give contacts of contacts and you vaccinate them. That's how people get protected and you can kill the outbreak. And as of what can we do now, of which we should start Ebola and other diseases, once there is human, animal, and environment interface, we will have these kind of outbreaks happening on a frequent level. And this is why One Health approach in dealing with these outbreaks, with the bats, our hunters are still killing monkeys, and we are close to the environment. Our mining companies, you remember the areas we're dealing with right now is a mining area, and our mining companies are getting an encroaching on a daily basis with the environment, and it's infected and it's infecting our people. That's how animal-to-human transmission happens, and then you have human-to-human transmission and an outbreak. So we need to work hard, as our Director General has stated, to get ahead of the curve. Over to you, DG. Thank you.
Thank you, Dr. Toro. Thank you, Your Excellency. We still have a few more minutes. If you would permit DG to take a couple of questions. Our colleagues are really interested in your responses today. So let's go back to the chat quickly. There are two questions that are related. One is from our colleague Julie from the AFP, and another one from Eva. Both questions are related, so I will put them together in one. They're all framed around the current conversation about the government of Kenya and the US government. So Judy first asked, can you comment on reports that the Trump administration works to open a treatment facility for citizens for US citizens in Kenya instead of facilitating their return for medical assistance on American soil? How far is the project and what do you think of it?
मम्मी मैं वो भूल गया। वो क्या रोहित? वो जो लेकर जाना था स्कूल प्रोजेक्ट। क्या? अब सारा सामान एक साथ।
That the US or US citizen exposed to Ebola quarantine will be quarantined in Kenya. How much will such plans stress the health system in Kenya, in a country like Kenya, and that already categorized as a high-risk country? So those are two questions that are related. DG, over to you and the team.
Thank you so much. My first answer is, so far, I didn't hear from the Kenyan government response, if this is the question asked to them. And as you know, I'm in contact with the senior officials from Kenya. And if a decision like that must be taken, we'll discuss and I will be informed. But from a purely technical perspective, I have to say that every country has the sovereign right to protect its population and to organize some measures during a public health emergency. If I'm asked what could be some concerns that I could have, I will say the first one is the additional pressure that this measure can add to the Kenyan health system. Kenya, as you saw, is already for us a high-risk country. It's a regional hub. It's a logistic hub. And adding an international quarantine responsibility for foreign nationals could stretch the national capacities, if it's not well supported by additional resources, infrastructures, people, and so. The second one I can also raise is quarantine facilities for high-risk pathogens like Ebola will require extremely sophisticated systems. And we need to think about infection prevention control, about waste management, about the intensive care. It's a system that we need to put in place. And I think we'll think about it when a decision must be made. The third one is mostly about the perception. Yes, we accept our role as African leaders, Africa CDC. When an outbreak starts in Africa, it must end in Africa. This is why we are working tirelessly to contain this outbreak. So far, the outbreak is contained in Ituri and 2 other regions in DRC and in Kampala, no other places. But we are not so familiar with this kind of policy of bringing people from everywhere to quarantine them in a specific country. And I don't know what will be the perception. If that one must be taken as decision, I will provide my recommendations to the Kenyan government. And it will be around what I'm sharing with you today, but I'm still waiting to see what will be the decision. Over to you, Nick.
Thank you, Your Excellency. Let's go back to our colleagues online. We're going to take another 3 in one batch, and we'll take the last 3 so that we can wrap up to this section. So we have hands raised, John Shango. John is with Radio Pan Afrique in the Congo. John will be followed by Patrick. Patrick is with Geneva Health Files. And then our chair in this batch will be, I know Dramani will want to speak in French. He is in Bamako. He reports for Radio Kiara in Bamako, Mali. So those are the 3 that will be taken in this batch. And after your response, we'll be taking the last 3. So John, let's start with you.
Yes, you are following me?
You can speak in French if you like. Yes, we can hear you.
Yes, I'll speak in French. Alors, merci beaucoup, Dr. John Kassea. Je suivis avec intérêt la présentation et je vous en remercie. Alors, ma question était de savoir, est-ce que Africa CDC a une crainte par rapport au niveau d'incontrôlabilité de l'épidémie? Excusez-moi le terme d'incontrôlabilité. J'ai dit incontrôlabilité parce que nous avons suivi des scènes qui se sont produites en Ituri et qui se sont soldées, n'est-ce pas, par l'incendie des structures où étaient internés les cas victimes d'Ebola, si bien que même certains se sont enfouis dans la communauté. Ce qui a, n'est-ce pas, élargi le champ de contact et de contamination. Et aujourd'hui, il se fait que, en tout cas, il y a une sorte de peur, de crainte dans la communauté. On ne sait plus comment s'y prendre. Ça, c'est la première préoccupation. Alors, rebondir dans cette préoccupation, je voudrais maintenant savoir comment est-ce que Africa CDC s'y prend déjà pour essayer de contrôler la situation. La deuxième question, c'est par rapport à la stratégie de communication. Quelqu'un d'autre en a parlé, mais je ne pas... Bon, la réponse du docteur ne m'a pas, bon, entre guillemets, satisfait, parce que je voudrais à ce que le docteur revienne sur, en tout cas, des détails très, très profonds sur comment est organisée la communication pour arriver quand même à endiguer la propagation de l'épidémie, parce que tout dépend, n'est-ce pas? Une grande partie dépend de la communication. Dès lors qu'il y a une grande quantité de rumeurs qui se répandent autour de l'épidémie, ça crée des cristaux et ça bloque, n'est-ce pas, la passation du message, l'appropriation de l'épidémie, de la lutte par la communauté qui est pourtant elle-même affectée. Merci beaucoup, Nek.
Thank you, Jean. Let's take Dramani. I know Dramani will also want to speak in French, and then we can take Pretty. Dramani?
Ok, merci beaucoup de m'avoir accordé la parole. Bonjour à toutes et à tous. Je remercie Jean Casséa pour la qualité de la présentation sur la situation de la maladie à virus Ebola en RDC et l'Ouganda. J'aimerais savoir quand il a parlé d'une déclaration de l'épidémie par CDC Afrique, il a parlé des 3 actions qu'ils ont menées. Si il peut rappeler ces 3 actions-là, j'aimerais savoir ces 3 actions-là. Après, c'est la seule question que j'ai. Je remercie Africa CDC pour ses efforts continus en faveur
taking my question. I'm Preeti Patnaik from Geneva Health Files. I want to know, Dr. Kasaya, about any coordination with the WHO with respect to the continental declaration, of the Ebola emergency and the fact that the fake declaration from WHO came a day before the World Health Assembly here in Geneva. What kind of coordination existed and, compared to the previous declaration during MPOX, for example? Thank you so much.
Thank you. DG, over to you.
Thank you. I think I will respond to Pretty. It's not Patrick, it's Pretty.
Okay.
And,
yes.
And to John. And my colleague will respond to Dramani. Let me start with John because it's in French and I know people are recording. It will help also for our people in the field to strengthen the communication aspect. And John, qu'est-ce que nous faisons dans notre stratégie de communication? J'ai dit, on met les communautés au centre de la réponse. Ça, c'est la première approche. Ça signifie quoi? On ne vient pas avec une stratégie qu'on a élaborée à Kinshasa ou en Europe ou aux États-Unis pour dire voici ce qui va marcher. C'est impliquer les chefs coutumiers, identifier des personnes de confiance dans chaque village. Le ministre est en train de créer aujourd'hui des comités communautaires Ebola avec des jeunes gens. Ce sont eux qui sont des leaders de leur communauté, qui vont comprendre On va même donner à certains d'entre eux des motos pour aller circuler et passer le message. Voilà, ça c'est la première approche. La deuxième, c'est passer d'une communication verticale à une communication de dialogue. Quand quelqu'un est en train de détruire, il ne faut pas venir lui dire « ne faites pas ça ». Mais il faut venir parler avec lui sur « pourquoi faites-vous cela ?» Qu'est-ce que l'on doit faire pour éviter cela? Vous voyez, ce n'est plus une injonction, mais ça devient un dialogue. Et nous allons utiliser pour cela les radios communautaires, les visites porte à porte. Nous avons maintenant des WhatsApp groupes. On a des églises. Nous allons aussi utiliser les radios communautaires comme arme principale de communication. Enfin, nous allons humaniser la réponse Ebola. Puisque la communication ne peut pas être seulement au niveau technique ou basée sur la peur. Il faut montrer des survivants. Hier, nous avions discuté de cela. Aujourd'hui, le ministre de la RDC a montré le premier survivant d'Ebola en Ituri. J'aimerais que la presse couvre cela, des messages positifs. Il ne faut pas que la presse relaie seulement des messages négatifs ou la peur, mais nous voyons qu'il y a des gens qui sont bien traités, qui sortent. Ça, c'est aussi un message positif. Voilà comment je peux résumer. Peut-être que je n'avais pas bien développé, mais voici ce que nous avons en tête. Pretty, let me make it clear and loud. At country level, it's the sovereignty of the country. In Africa, it's the sovereignty of Africa CDC. In the world, it's WHO. Let us respect the three layers. I didn't declare this outbreak when it was only DRC issue. Because if it's the DRC issue, it's the government DRC to declare that. When I got evidence, and let me tell you what I'm telling you now, I'm supported by all leaders I met, and you also had the opportunity to listen from the chairperson, African Commission, who said we are supporting the declaration made by Africa CDC. This declaration was when we had evidence that at least 2 countries are infected. When we have that, we don't have to request for permission. It's our mandate to support our people. But we didn't declare at that moment the public health emergency of continental security, because in our statute, to do this kind of declaration, we need first to call for you must have also recommendations. Because the day you lift that, you must say that I respond to all recommendations, and then we can lift that. It's not just a political declaration. It's a powerful tool. And I don't want WHO, Africa CDC to start to use that just as a political momentum. No. Because what we are facing today, the fear that we are facing, sometimes it's because we need to understand the consequence of what we are doing. We had the emergency consultant group that met. I had to consult the chairperson of African Union Commission. I have to consult President Ramaphosa as the champion. I have to consult countries and leaders. Then I could declare the facts. We respected that. Our declaration is at the same time a political one because we are bringing leaders together to see how to respond to this outbreak. A strategic one because we are bringing partners to support, and a technical one because we have clear recommendations on how to respond to this outbreak. What are measures we need to take to respond to this outbreak when we know that we don't have vaccine and medicines? This is what we did. And I will tell you, we have dialogue with WHO. We'll continue to have dialogue with WHO. And in the future, we'll see, maybe it will be before declaring fake, we first start with fakes in Africa if another continent is not affected. But if other continents are affected, this is understandable to start with fake. But we are still, it's a conversation that we are having, and we'll continue that.
Thank you, Your Excellency. Our colleague, Renin with Bloomberg, based in South Africa, has been up for a while. So she's going to be the last person to ask today. We're already almost 5:30, so we're going to wrap up with her. So over to you, Renin.
Thank you very much for the opportunity. I just want to go back to a remark that DG's had towards the beginning of the briefing, where he said that some of the funding pledges that was announced earlier in the week has not come through or was maybe withdrawn. So I'm just trying to get a sense of where do we stand now on funding pledges, the amount, and if there had been withdrawals, which funders had pulled out?
Let me make it clear and loud. When we are negotiating the pandemic agreement, we said when there is a pandemic or when there is a huge outbreak, we take money from development to support the response. People are dying. How can we come and say we commit X $million and the next day they are calling me to say, no, it was a mistake. We didn't really want to say that, but this is exactly what we have or what we are committing to provide. We know some big global health institutions are sitting with billions of dollars. How do you want to conduct your program if countries are affected? Priority today, Uganda and DRC, their priority is to fight Ebola outbreak. How can you come to say, I want you to focus on this development program and have money for that, but I don't have money for Ebola? I don't say we need to stop development, but I say, as we discussed during the pandemic agreement, let us give opportunity to countries to stop what is killing people now, to repurpose funds. I want to thank World Bank. I want to thank FDB. They told me we are repurposing some funds to support the response. Thank you, World Bank. Thank FDB. I want to call upon all other global health initiatives. Today, I will not name them. I give them 1 week. Next week, for my press conference, I will name each of them. I will put them accountable. I will see, how do you want people to implement the program you are supporting if they are dying and they don't have support for this Ebola outbreak? How can you keep quiet? Because most of them are keeping quiet today. And this is not acceptable. They must know that. Thank you.
Thank you, Your Excellency. Thank you, colleagues, for your active participation into this section. It has been really engaging, and we're encouraging you. You have our contacts as the Communication Department of Africa CDC. We will always work to support what you need from us in terms of interview with our experts and your questions coming in to provide responses to them as we all fight to tackle this outbreak in our member states. Your Excellency, at the end of this session, we would like you to send your final message to the community. The journalists are here. What you want the community, the people in the community, affected area in the DRC, in Turi province, the different areas there, and of course, Uganda, in Kampala, where the people are affected. What would be your message to them as they go through the daily constraint of Ebola? Thank you, and over.
My people, you know, when a country is attacked, you want to see a general leading the army. That is giving you hope and confidence. Today, I want to tell you, this is why you created Africa CDC. Your Africa CDC. We are up. All of us with our member state to fight this disease. Today, we are looking for all ways to support you for diagnostics, for PPE, for medicines, for communication activities, but we are also asking you to lead your communication response in your village, in your communities, in your district. We want you to think about how to change behaviors. We can discuss that, but it's important to listen in Uganda, in South Sudan, in DRC, but also in all countries at risk. Our commitment will not stop till when we make sure that this outbreak is no longer a threat for all of our countries. We'll continue to work closely with our partners, WHO, UNICEF, with our private sector to support our member states to fight this outbreak. This is the commitment. In addition to that, we'll continue to see how to accelerate for vaccine and medicines. Thank you so much. We'll continue to fight together.
you.